Hey folks, I wanted to talk about the Essure removal once again, and not sound like a broken record, but I wanted to kind of go through some things that I've been seeing, and to hopefully, if there are some questions during this live broadcast, I'll be more than happy to answer them. But I wanted to talk about some issues that I've been seeing and kind of come up with some things that I think we should expect. I mean, what should you expect? Well, I think first and foremost, you should expect that you don't need to have a hysterectomy. And one of the reasons that I started the Tassone method webpage on Facebook, if you search Essure removal Tassone method, it's to talk about how I feel is the right way to do the Essure removal itself. And short of a hysterectomy, which I think anybody can do. I had a patient ask me the other day if she needed to have it done with me, and while I'd like to be able to do help everybody, obviously as a gynecologist, anybody can do a hysterectomy. So I think that as long as the tubes are being removed with the uterus, and you have a situation where the hysterectomy is being done laparoscopically, or a laparoscopic assisted vaginal hysterectomy or an abdominal hysterectomy, I think you're okay to have it done that way. What you don't want to have is a hysterectomy that's being done straight vaginal. And so I think that that's important to note. I'm just checking to see if there's any comments. Nothing yet. Just because number two would be just because just because a doctor wants to help, and there's obviously on other pages doctors lists, which are great, but that doesn't necessarily mean that a doctor knows how to do a salpingectomy. Obviously means those physicians have probably helped. Some of them on there may be doing very good work and are wanting to help, but do they know how to do a salpingectomy? And the salpingectomy is where we just remove the tubes and the coils. So what you're going to want to do is you're going to want to ask those doctors, if they propose a salpingectomy, how are you going to do the procedure? And can you draw me a picture? So not just are they going to do it laparoscopically, but how are they going to remove the coils from the uterus, especially if it's a grade 2 insertion? How many have they done? And then have them draw you a picture, because you want to be able to understand this. A doctor who's closer, while obviously is more convenient, isn't necessarily the best approach, especially if you want this done right, because you're only going to get it done once the first time. You don't want to have two surgeries. And unfortunately, I am seeing a lot of women now that are having to have a second surgery. There's other doctors in the States. I'm going to be starting a new course for physicians who I can then have you search my website by zip code and find those doctors that are doing things correctly. And that's going to roll out in the next 2 weeks. I know there's a physician in Ohio named Aurora. I've spoken to him. There's a doctor in Nashville named Junker. And I've spoken to her, and it sounds like they're doing some really good work. So as this starts to expand, you're going to want to be going to people that are doing things the correct way. And like I said, you only get one chance to remove these the right way the first time. Nobody wants to have fragments or a second insertion. Doctors, in my opinion, that are still placing coils probably shouldn't be doing the removals. And I don't mean that in a derogatory means. I mean, I guess I'm saying if they are indeed still doing the insertions, then my guess is they probably don't fully comprehend that they could be causing problems, and that they probably won't be in the best situation to help. So that would be my my recommendation. Yes, Jerry. Jerry's asking. Let me see if I can put it on here. Jerry Bailey just asked. He's a friend of mine. Where do you send your OB friends? In a week or so, there's going to be a website called removemyessure.com, removemyessure.com, and that will be up and running in a couple of weeks. And what that's going to have is a website for doctors to see the correct procedure. It's going to be a way for them to know the preoperative ins and outs, postoperative issues that we've seen, how to code it, how to bill it so that you get the benefit of that being billed correctly the first time, insurance accepting it. Obviously, that's not going to work for reversals, but we also teach them how to train their office staff. So for you women that are coming in from out of town, which is a huge portion of these clients, patients, we also know how to, they'll know how to do that as well. Thanks for that question, Jerry. And I think, and getting back to doctors that are inserting, doctors that are dabbling with removals, they'll say, oh, I've done a few, or I've done 10, or I've done some removals. I don't think that you should be going to somebody that's dabbling with removals. You wouldn't go to somebody who's dabbling with hysterectomy. So why would you go to someone that's dabbling with removals? I think if you're going to have a self-injectomy where just the coils are removed, then you need to see somebody that's done a bunch. And I'm talking probably more than 30. How long after removal can you return to work? It depends. If you're having the coils and tubes removed, then Erica, what you're going to see is probably a week to 10 days before you return back to work. Hysterectomy is obviously a little bit more involved recovery-wise. It's more involved surgically. But I've seen women that have desk jobs go back to work in 1 to 2 weeks. You're going to be a little bit sore, but you're still going to be very functional. I think that doctors should be checking hormone levels as well. I think that you have a situation where you have a known neuroendocrine disruptor with those polyethyl terephthalate fibers, stainless steel, nitinol. You have issues with hormone levels. I have been doing hormone levels on everybody, and what I've been finding is 90% plus are in an estrogen dominant phase and a testosterone deficient phase. And I can help with those hormones dramatically before you even have the surgery. So I think it's important. I think that it's something that benefits the patient, and I do it on all of my patients that want to have it done. I think the physician should know more than you about the coils. I think that you shouldn't have to educate them, but obviously that happens. I think it's good that you know a lot about the coils and that you know a lot about removals, but I don't think that it's something that you should have to do, and that's why I'm wanting to educate the doctors on proper removal. The doctors should know more about other options than hysterectomy, and they should be adequately describing it to you. I can't tell you how many women I've seen on the internet here talking about patients who or doctors that are proposing surgeries that just aren't going to get the job done, or they're removing one coil. I just had a lady today on the Texas site who said she had one coil removed. Why are we removing one coil? If you're in there and you're doing the surgery, why on earth are we removing one coil? I've had women come in from out of the state that have vaginal hysterectomies where they have pieces left behind, or 4 coils or 5 coils. And I think we need to really get doctors up and running and educated on proper removal, and not just that, but how the procedure should be done, and based on numbers, not just based on shouldas or couldas, but based on actual data. The pathology department that those hospitals, that those doctors work in, should know how to handle the specimens. Anybody that works at a facility where they're going to be getting letters from attorneys or whatever, one of the ways that physicians or that if we got the coils out short of the operative note, and I'm sorry, but I had a patient last week that I did a surgery on who was told by the doctor that he definitely removed both coils, no questions asked, and on x-ray she still had both of her coils in. The pathology specimen will tell you, in a good pathology department that's been well trained with these coils, it will tell you if the coils have been removed and have they been removed in toto or in total. You should always tell them you have the Essure and expect them to understand and listen. You should tell the doctors that you have the Essure coils. I like the advice that you have to pussyfoot around the actual fact that you have Essure. When you call the office, don't mention the Essure, just mention your symptoms. Why? One, it doesn't help the doctor if they're trying to remove the coils. If they don't even know that you think that the Essure coils are causing the problems, then how are they going to know to remove them? But it will also tell you up front if you're dealing with someone that's sympathetic. And I know that you just want them out and you're tired of them. But I think in the next month or two, as we start getting some physicians on board with this training program, you're going to have people available to you. So I would put the brakes on getting this done by somebody just because you want them out right away and you haven't told them at least that you have the coils in. They need to have good surgery proper self-injectomy. And what I mean by that is this is not a simple self-injectomy or a simple removal of the tubes. Most doctors will say, of course I can do a self-injectomy. And you know what? They can. Anybody can do that. But this isn't a simple self-injectomy. This is a coring self-injectomy. This is a partial cornuectomy. This is something where you have to make sure that you remove the coil all in one piece and that you're not pulling on it and that you're trying not to leave back any fragments or any fibers. And this is something that I believe should be done in a training. It shouldn't just be something that's described over the phone. And certainly you shouldn't have to describe how to do this to the doctors. They should know how to do this. I think they should be mentored by somebody that's done more than 30 cases. I don't think this is something that the physician should just look at on the internet or talk to somebody on the phone. This is something that I think a training program that talks with multiple methods, that shows videos, that shows case studies, complicated cases, has an open forum where doctors can get together and talk about difficult cases in a safe environment where we can share data as physicians, and that's what I'm trying to provide. You shouldn't feel threatened or stupid for asking questions. I mean, my God, that's what you're supposed to do at the physician's office. You shouldn't feel threatened. You shouldn't feel like there's something wrong with you for saying that you think it's the Essure coils. And if you're belittled, if you're made to feel that way, then I would recommend getting a second opinion. You should feel safe. You should feel listened to. While money is important to those with high deductibles or no insurance, there are other options. And I know it's expensive because it's surgical. And I know it's hard to pay for. That's why at my office, I've tried to come up with a financing plan called Parasail, which spreads the payments out over 24 months. It pays for surgical fees. It pays for anesthesia. It pays the hospital bills. It will pay for your travel. You finance all this and then you pay it out over 24 to 36 months, I believe. It's kind of like a credit card. I know it's not the best method, but for those women that have high deductibles or those women that have no insurance at all, it is at least another option that you have. You should feel acknowledged. You should feel like even if that doctor doesn't necessarily believe that 100% of your symptoms are coming from the coils, and we know that 100% of our symptoms all the time can't come from the coils, but some of them certainly can be, and maybe a large percentage can be. But you don't want to feel belittled. You want to feel acknowledged. And if that doctor says to you beyond the shadow of a doubt, there's no way that these coils are causing your problems, then you need to get another person in and to find somebody that actually might be able to help you. And you should finally and wholeheartedly expect to feel normal again. I mean, normal is a relative term, right? But why would you be told that, oh, more pain or more bleeding or more weight or more this or that is just because you're getting older? I mean, can you imagine what could you say? I don't even fathom that. But women are told that all the time, that all of your problems are just because you're getting older. Weight, I can understand, but pain, that doesn't even make any sense to me. So don't take that as a reason. I don't think that's a valid reason. I think that if the patient says she's in pain, we need to investigate this further and we need to figure out what's going on. So I'm going to stay on for a little bit longer. Maybe somebody will have some questions. I know I just sort of popped in and did this and didn't really propose it to anybody ahead of time, but I just had some free time. So I figured I would get online and start kind of explaining what I would consider the Essure Patient's Bill of Rights. There's a new book that Dr. Sills, Eric Sills in California, is coming up with that's going to be multi-chaptered case studies, case series, and research projects on the Essure coil, and hopefully that will be coming out at the end of the year. My course for doctors is going to be coming out at the end of this month. I've already got 3 surgeons that I'm going to be putting through the beta testing program to make sure that we've worked all the bugs out. These physicians will be readily available in Arizona, Oklahoma, and hopefully Nebraska right off the bat at the end of the month. I'm hoping to get my goal would be to get at least 20 to 50 physicians in every state to handle the volume of patients that really want to have these things removed the right way. And hopefully we can give patients options of not only hysterectomy, but a well-done bilateral salpingectomy and partial cornuectomy. So since it looks like nobody's kind of chiming in, because I kind of just threw this together at the last second, which I understand but it's spring break this week, so I had some free time, and South by Southwest is in town, so gosh forbid we don't want to leave the house because traffic is crazy here in Austin. But I'm going to post this video to as many of the Essure websites as I can. My Essure site is Tassone Method Essure Removal. So if you're on Facebook and you type that in, I'd be more than happy to have you. Pam says my doctor office no longer uses Essure. Juanita says yes, we're busy. Aren't we all? But yeah, it's great if doctors' offices aren't putting them in. That tells you right there that at least they're listening to the patient demographic that aren't requesting these anymore. And I think with the FDA black box warning that's now out there, a couple of the docs I've spoken to said once they read the FDA black box that the patients would rather proceed with a different procedure anyways. So I think it's really important to, for that instance, for those doctors then to consider removing them. Yeah, thanks, Juanita. I'm trying to do it. I've tried to do it at different times, and everybody's so busy. Sometimes at night, then you're busy with your kids and getting dinner ready or putting them to bed. So there's really no great time. The thing about these live Q&As is that at least you can put questions down below in the comments, and I will promise to read them. The other thing that these videos do is they help bump Essure removal in the topics for Facebook. So the more views that we get, the more comments that we get of it, Facebook rewards that and bumps things up a little bit. So I think it helps in general to kind of keep the discussion going. It might bring some doctors in. I know that in May, there's going to be a lot of rallies going on. I'm hopeful that the women that are going to the ACOG meeting in San Diego, they're going to be out front handing out brochures and education materials. I hope that some of my colleagues will be a little bit open to the message and at least looking into it. The first step for a lot of these offices is that they stop putting in the devices. So that's always a sign that maybe we're making a little bit of progress there. And that now we just want to make sure, because the second wave of problems that I foresee is that, you're welcome, is that we have situations where, thank you, Pamela, is that we have set up where now we're having women that have well-meaning doctors that are removing the coils, and they're wanting to do the least invasive procedure that they can find, but they're doing the procedure in a way that they're pulling on the coils, they're fragmenting the coils, they're cutting through the coils. And believe me, I get contacted about 20 times, 25 times a day from women around the country. I have a lady from Asia that's coming to see me in a couple of weeks, that they're just not being done correctly. And it's not just in our country, it's everywhere. They're doing what they think is correct, and that's great, but there's no great standardized way to remove these. And I think we're going to start seeing more and more issues with these. So I think we're coming up on about 25 minutes, give or take. I wanted to just say thanks for the kind words. Thanks for the comments. Keep the ladies in your thoughts that are having upcoming surgeries. If you have questions, feel free to ask. You can always call my office and talk to Amber or Angela at 512-533-4141. They'd be more than happy to ask questions. Leslie at my office is our biller. She knows more about the financial side of things, and she also can help with insurance questions. But feel free to reach out, ask as many questions as you can. I hope that women find this website. So go out there and promote the sites that you're on and promote the message. And we will talk soon. I hope that you all are doing well, and I'll see you the next time.